Thanks, Jack, for that interesting talk. So many apologies. I forgot to mention that if you have any questions, just fire away in the chat box, so you can ask anything on this topic, and we'll compile all the questions and ask the speakers at the end of the session. So for next talk, so I would like to introduce Dr. Haifa Lyster. So she is the consultant pharmacist in cardiothoracic transplantation and mechanical circulatory support at Royal Brompton and Harefield Hospitals. Dr. Lyster co-founded and is the vice chair of Solid Organ Transplant Pharmacy Association and past chair on the Advanced Heart Failure and Heart Transplant Network for the International Society of Heart and Lung Transplantation. And she is completing her PhD on PK of antifungal agents in critically ill patients receiving ECHO.
Thank you very much for the invitation. I'm just going to go through in the next about 20 minutes on antifungal dosing in obesity, by disclosure slide. So as touched upon by the previous speaker, obesity is defined as a body mass index of 30 kilograms per meter squared or more, with morbidly obese classified as the class 3, where the BMI is more than 40 kilos per meter squared. From the WHO, that you can see that there is significant global public health concern associated with the increased risk of comorbidities, as well as post-operative and nosocomial infections, and obesity is increasing worldwide. This only goes up to 2016, but even during that time, it has increased. As you can see in here, so the United States, Australia, and the UK, approximately about 30% of people are obese worldwide, with about 65% are classed as either overweight or obese. As you can, so it's becoming a large problem to deal with in terms of our patient group. So obesity increases the risks of various infections, as I mentioned. Candida species are responsible for about 15% of bloodstream infections, which can lead to prolonged hospitalization and increased mortality. This study, or this paper, was a retrospective cohort study in about 88 patients, 28 of which were obese. And the primary objective was infection-related length of stay, with secondary objectives with the time to resolution of the candidemia and 30-day readmission rates and mortality. As you can see, there are worse clinical outcomes observed for those that are obese versus non-obese. So actually understanding how we dose these patients is going to be quite important. Body composition is increased proportion of adipose tissue and decreases proportionally to skeletal muscle. The weight increases in both lean and fatty mass, and there's a higher proportion of fatty versus lean. In normal weighted people and subjects, the lean to adipose is 4:1. In obese, it's approximately 3:2, because there's an extra 20 to 40% increase in lean body mass. So all of this will affect in how we potentially dose patients, and how the pharmacokinetics of drugs are handled. So the BMI is crude. It's based only on height and weight, so it's a poor dosing metric. So other metrics, such as the body surface area, is commonly used for things like chemotherapy. Ideal body weight is often used to dose medicines that do not distribute into adipose or other tissue. It characterizes height and gender, but as the previous speakers mentioned, it doesn't account for differences in body composition or the increase in absolute lean mass, and that will also accompany obesity. So if we use total body weight, it assumes that the pharmacokinetics of the drug are linearly scalable from normal weighted people to obese patients. This is inaccurate, as clearance differs. And sometimes if we're worried about toxicity, we might actually either use a dose reduction or cap the dose to avoid toxicity. This also then has an issue in that fact that pharmacokinetic changes that occur in obese patients can present challenges when administering medicines to this population. So if a patient is in the critical care, there are lots of other factors that can also affect the way these antifungals or drugs in general are handled. So simple adjustment based on total body weight or some component of it cannot be applied across all patients or drugs, since changes in blood volume, organ size, or metabolic capacity are not uniformly related to the body weight alone. So, for example, in scenario A, the drug is an example of a drug that is inappropriately dosed using using total body weight. And can result in supratherapeutic concentrations with the risk of adverse events. With scenario B, in using the ideal body weight inappropriately, you have the opposite. You can have extensive distribution and resulting in subtherapeutic concentration and hence treatment failure, which is a problem when it comes to anti-infectives. So how does the impact of obesity affect the pharmacokinetics in terms of the volume of distribution? So understanding this, how the drug is distributed into different body tissues will be critical in predicting the effects of obesity on the concentration. Understanding how it affects the volume of distribution, as we know, will be critical to understanding to determine the loading dose that we might want to use. And it is affected by several factors such as the body composition, blood flow to different organs or tissues, protein binding, as well as drug characteristics, which include lipophilicity, ionization, and the ability of the drug to cross biological membranes. In terms of protein binding, obesity does not seem to impact drug binding to albumin, but there's contradictory evidence with regards to the alpha-1 acid glycoprotein and the increases in the free fatty acid, and see whether those actually can modify the volume distribution with certain drugs. In terms of its impact on clearance, so clearance is the primary determinant to consider for determining your maintenance dosing regimen, and it's often largely controlled by the patient's renal and hepatic functional physiology. It's correlated mainly to lean lean tissue rather than adipose, as adipose tissue has little metabolic activity. It's also important to note that these patients will often have other comorbidities, so may have CKD, and in terms of hepatic, there's accumulation of fat in the liver, which will alter the hepatic blood flow and will also decrease drug metabolism. In terms of obesity and diseases associated with it, these can provoke metabolic and inflammatory alterations, which can be described as chronic pro-inflammatory state, which will affect things like the CYP enzymes and some of the other transporters. So there is evidence to show increase in the CYP2E1, which isn't involved in many drugs, but it will decrease the activity of the CYP3A4, which is involved in a number of antifungals, in particular the azoles, and some of the phase 2 metabolism via glucuronidation and sulfation. In this recent review, it's a nice pictorial that shows you the effects in terms of critical illness and obesity. So ideally, the one-size-fits-all paradigm should be replaced by individualized dosing methods, and because the significant variations in PK/PD due to the weight, so obesity, age, genetics for certain drugs, and comorbidities and other factors all have to be taken into account, and where possible, have therapeutic drug monitoring. So if I move on to the antifungal groups, so for the azoles, these are often first-line treatment for a number of invasive fungal infections. They are predominantly lipophilic, except for fluconazole, which is hydrophilic. Isavuconazole, which isn't actually on this table, is a highly water-soluble prodrug, but the active drug itself is very lipophilic and also highly protein-bound. In terms of the pharmacodynamic index, they display concentration-dependent activity with the AUC over MIC ratio being the PK/PD index. With fluconazole, increased doses results in predictable increases in the AUC. Therefore, it doesn't actually warrant therapeutic drug monitoring. With the drugs such as voriconazole and posaconazole, AUC correlates very well with the trough and therefore allows for TDM. There are a few studies that look at specifically in obese patients. So this study by Al-Obaid et al. Looked at a population PK study. It included 6 obese and 4 morbidly obese and 11 non-obese patients. And they found that the volume distribution correlated with the body mass index, and that the clearance correlated with the creatinine clearance. They demonstrated that higher fixed doses of greater than or equal to 400 milligrams were needed to achieve the AUC-MIC ratio of greater than 25, for organisms with an MIC less than 2 milligrams. However, if the BMI was greater than 40 and we required higher AUC-MIC ratios, then doses of greater than 800 milligrams per day may be required. When they did their modeling, they found that loading doses of 12 milligrams per kilo using total body weight, followed by maintenance doses of at least 6 milligrams per kilo per day, adjusted by the renal function of the patient, were necessary to maintain the adequate AUC-MIC ratios of greater than 100 for susceptible patients. When going on to voriconazole, there are, again, a number of studies with this one evaluated the steady state plasma pharmacokinetics of voriconazole through a 2-way crossover design in a cohort of 8 healthy volunteers with class 2 obesity or greater. So patients were given an oral maintenance dose of either 200 milligrams or 300 milligrams twice a day, both after receiving a loading dose of 400 milligrams twice a day for the first day. The pharmacokinetics of voriconazole in obese was compared to historical non-obese patients, and it was found to be similar between groups that received the 300 milligrams twice daily dosing. In the obese patients receiving the 200 milligrams, voriconazole clearance was decreased by 50% with proportional increase in the AUC. However, they did find that the volume distribution was similar between the 2 groups, and that the AUC correlated with lean body weight greater than and then adjusted body weight and ideal body weight, with total body weight having little correlation. There were 6 studies that used TDM to describe the effects of obesity in voriconazole concentrations. 2 did not find weight as a significant covariate. However, the top one found that they compared voriconazole concentration dose based on total body weight, adjusted body weight, and ideal body weight. And they found that the use of the adjusted body weight resulted in a higher number of patients reaching the target range, with fewer patients having super therapeutic concentrators toxic levels in comparison to using the total body weight or ideal. And then when we go on to posaconazole, it's a broad antifungal license for prophylaxis and treatment of invasive fungal infections. There was a prospective population PK modeling to assess the effect of body size on posaconazole. They used IV dosing that total body weight best predicted clearance and volume distribution, but with a lower exposure in obese versus normal weight patients. Body size had a significant impact, resulting in lower exposure. So for treatment, the dosing recommendations here were a starting point and then followed with TDM. So for prophylaxis, they found that 300 milligrams dose was adequate. In treatment, in patients that were obese of greater than 140 kilos, you might want to consider increasing to 400 milligrams. In another study using oral, they evaluated the POSA trough levels in 28 patients undergoing chemotherapy or that had received stem cell transplant. In patients greater than 90 kilos, they found lower trough levels. There aren't any studies really with isavuconazole, but similar to oral posaconazole, it's probably not to be found to be a difference in terms of exposure with weight. But going on to the echinocandins, again, these are highly protein bound. They have a very similar chemical structure across the board between the 3 of them. So For the first one, anadulafungin, there are two papers from Liu et al. The first of which was a population PK, where they analyzed 4 phase 2 and 3 studies with varying dosages. The weight increase resulted in decreases in the AUC and the Cmax, and increase in clearance. They found that the data from 7 patients that were greater than 120 kilos did not appear to have worse clinical outcomes, and there were no and they concluded no dose adjustments were required in obese up to 150 kilos. They then subsequently did a POP-PK study in 20 critically ill patients with weights varying from 48 to 106 kilos. They had one morbidly obese patient of 240 kilos who received 150 milligrams as their maintenance dose. They found that the PK parameters of the morbidly obese patient fell within the ranges observed in the study overall. And if they extrapolated it, the dose down to 100 milligrams, they would have had subtherapeutic levels. So they suggested a dose increase of about 50% of patients, in 50% for patients greater than 200 kilos, or those with a BMI of greater than 80. In another study where they looked at the PK in morbidly obese of 8 patients, and they compared it to 12 normal weight patients using a single 100 milligram IV dose. Again, they considered 25% increase in loading and maintenance doses in patients greater than 140 kilos. So basically, you can use normal doses up until that kind of dose, and then consider increasing doses to 25% in 140, and then if the patient is over 200, you might want to consider going up by 50%. These drugs are pretty well tolerated in using these higher doses. So caspofungin, they in the first top study by Hall et al., they looked at prospective single dose of 70 milligrams, a study in 18 healthy volunteers. There were 3 groups. There were normal weight, or those that were overweight or obese, or morbidly obese as the third category. Total body weight had a positive correlation with both the volume of distribution and the systemic overall clearance, and had a negative correlation with AUC and peak concentration. And their conclusion from the authors were that to increase the dosing in heavier patients in order to reach the AUC over MIC PD targets. A recent study looking at the POP-PK of caspofungin weight-based dosing in critically ill patients. They looked at 20 patients, and they looked at 2 milligrams per kilo as a loading dose, followed by 1.25 milligrams per kilo as maintenance doses. They found that 98% of the patients were expected to reach the AUC target on the first day using this dose, and 100% on the patients on the third days. Concluding basic current doses of 70 milligrams or 50 milligrams if the patient is less than 80 kilos may not be suitable for patients that are overweight. Then for the third and final of the echinocandins is the mycofungin. They looked at prospective study in 16 obese and 8 normal weight healthy subjects, weight ranging from 61.5 to 184 kilos. They found that total body weight was most predictive for both volume of distribution and clearance, and suggested that maintenance dose should be increased to 200 milligrams in patients greater than 125 kilos that were infected with Candida species with MICs up to 0.016. If you had a less susceptible or required an MIC of 0.032, 300 milligrams maintenance dose would be recommended in patients greater than 125 kilos. You might want to also consider a loading dose of twice the maintenance dose on the first day. The authors presented in this figure a nice, easy-to-use dose recommendation for these patients based on both weight and target MIC that can result in adequate exposure in patients with body weights up to 190 kilos. With regards to another study for a POP-PK-PD in 10 critically ill non-obese patients, and then they compared it with 10 non-critically ill obese and 10 morbidly obese critically ill patients. This study estimated the mycofungin probability of reaching adequate AUC over MIC values against Candida species. They found that the FDAs were greater than 90% with Candida albicans with 200 milligram maintenance dose for all body weights up to 185 kilos and with 150 milligrams per day in those that were less than 115. With the Candida glabrata requiring up to doses of 200 milligrams daily for body weights up to 115 kilos. So finally going on to the last one, which is amphotericin. There aren't any studies in other than the liposomal amphotericin that looked at morbidly or obese patients. This study done a few years ago looked at fixed dosing of liposomal amphotericin in morbidly obese individuals. So although the AUC and the Cmax have been reported to be associated with efficacy, the AUC has also been associated with increased risk of toxicity, in particular renal toxicity. So in this prospective study, the authors explored the PK of 1 and 2 milligrams per kilo liposomal amphotericin, like I said, in 16 morbidly obese patients with weights of 104 to up to 177 kilo. They found that body size had no effect on clearance. That the body weight resulted in increased risk of toxicity in these patients. So in obese patients specifically recommended using the licensed 3 or 5 milligram per kilo dose, that they capped the dose up to, in patients above 100 kilos, to 300 or 500 milligrams per day, mainly, like I said, to minimize toxicity. So what now? The data, like I said, in a lot of studies, there are, in terms of regulatory studies, there are not many that have studied in obesity. And so exploring this, the data in, like I said, in azoles is limited. Voriconazole correlates best with the adjusted body weight for both the IV and oral, but due to the high interpatient variability and influence, as we know, of pharmacogenomics of the voriconazole, TDM is recommended. Fluconazole is total body weight with loading doses of 12 milligrams per kilo, and then maintenance dose of at least 6 milligrams per kilo. With posaconazole, the dosing is inconclusive. However, as we mentioned before, for prophylaxis, probably 300 milligrams with the IV dosing is sufficient in individuals up to 140 kilos. But you might need to increase it up to 400 milligrams if you're looking at it for treatment doses. With isavuconazole, it's unaffected by weight. And then going on for the echinocandins, it's similar, a message across the board for all three, that doses for all agents are likely need to be increased in obese patients. And as mentioned, these drugs are pretty well tolerated across the board in terms of their higher dosing. So caspofungin and micafungin might want to be increasing doses, even at starting at 150 milligrams could be considered. And with anadulafungin, the loading dose and maintenance dose to be increased by 25% and 50% in patients weighing greater than 140 or 200 kilos respectively. And in this, that reference there that I've put in there, that's a nice, good overall review up until 2019 of the studies that come through with antifungals. And then finally, this just as a reminder of the TDM. In terms of the azoles, unfortunately, we do not have, definitely in the UK, routine TDM for the echinocandins. I'm not sure whether you have them in Australia. But so it's about having availability of these TDM service and also the turnaround time for reporting. Always also consider drug-drug interactions, and in particular for voriconazole, the potential for pharmacogenomics to influence dosing and drug handling as well. Thank you very much.
Thanks, Haifa.